The following is a conversation with Chadi Nabhan, Chairman of Precision Oncology Alliance at Caris Life Sciences. We talk with him about good medicine, the art of being human in medicine and healthcare in general, actually caring for patients, and the essence of science and its abuse in current times of COVID. With his podcast, Healthcare Unfiltered, his perspective articles in Journal of Clinical Oncology, JAMA, and others, he is really a human voice in an ever-challenging environment of pretenders. Previously, Dr. Nabhan was an associate professor of medicine and medical director of the Clinical Cancer Center at the University of Chicago. Please check out his podcast and his texts. And if you like this episode, feel free to leave feedback and share this video or audio links on Spotify, Apple, and others. And now, enjoy this conversation with Chadi Nabhan. What was the idea when you started your podcast? How did you get the idea and how did you start?
You know, when you ask this question, you give me a little bit more credit than I deserve. And I'm humbled that you ask because, I mean, I think, I think we all are amateur in this in this media outreach type of thing. But the way this has really started was maybe several years ago with a different podcast called Outspoken Oncology. And I had actually a poster at one of the ASH meetings. Maybe it was ASH 2018, and it was a real world poster on CLL and the use of venetoclax. I think I was a co-author. I wasn't even the first author or the last author. And one of the editors at a small journal called the Journal of Clinical Pathways interviewed me about this particular poster. And as we got to talking, I shared that one of my interests is to have a platform or just because I always felt there's something missing. And I wanted to have a platform where I bring guests to give them an opportunity to, offer their views or debate views and so on. And he said, well, we may be interested in possibly sponsoring this podcast, and maybe possibly we could even produce it for you, and then you will control the content, the guest, and everything, and we just will produce it and put it on our website. So I started that. We called it Outspoken Oncology. That was in February 2019, and I recall the first episode aired either February 19 or February 26, 2019, and it was pretty nice. I mean, I enjoyed the fact that I was really having different guests and different topics, but still had a flavor of oncology in it. And then towards the fall of last year, so in the fall of 2020, I've decided that I want to have my own podcast. I don't want to have any, the sponsor had really no say into the content or into the guests, but I really wanted to have complete control. Part of it is I wanted nothing edited in an interview. So I didn't want, even if somebody is swearing and cursing and just being angry and so forth, I want it all unfiltered. So I call it Healthcare Unfiltered for two reasons. Number one, I wanted to branch out of just oncology, and I wanted to address different topics beyond oncology. And I did not want to have any editing into whatever the guest is saying. I mean, the only thing that we do is sometimes we add the music, obviously, before and after, just to have it somewhat of a production into it. And if there are certain things like interruptions that we just need to edit and so on. So that's really how I started. I've honestly enjoyed the process. I'm trying to increase it as much as possible. I'll tell you more about it as you ask me questions, but that's how it started.
And we never met before, so I needed to do a little bit of research about you. And I found that you studied medicine in Damascus. Is that correct?
Yes, that's where I went to medical school, and I left Syria in 91 or 92.
Okay, and you were born in Syria and lived there for how many years then?
Throughout medical school. So medical school in Syria is you go directly after high school. So you finish high school, and then there's usually, depending on your grades in high school and how many seats in the medical schools and how many people apply, there's a formula. You get to apply right away. There's no undergraduate or there's no college and then medical school. So I did, you just go directly into medical school or law school or dentistry and so on.
And do you still have family there?
Yes, all of my in-laws are there, and also I have a law family on my side. My parents are in the U.S. right now. My brother lives in the U.S. as well. He's a physician at Ohio State.
And what made you come to the USA?
Really, to do a postgraduate training. I mean, I wasn't sure. I mean, to be honest, I wasn't even sure I wanted to do medicine. I wanted to do journalism and communication, if you ask me. But I did pretty good in high school, and I was able to apply to medical school. So it just made sense to do that and leave the other aspects as a hobby, because medicine has more financial security and so on. But the US had an opportunity for postgraduate training that is very competitive. I was contemplating going to Germany, frankly, because I have an uncle that lives in Germany and he's a physician there. He's been there for a long time. But even he told me, he said the opportunities in the US are probably better than Germany in terms of foreigners trying to pursue their postgraduate training. So he said if the opportunity comes, he would suggest that I would try to come to the US. So I did, and so I go back and forth, but really was to pursue residency, fellowship, and additional research opportunities.
Mm-hmm. And when you reflect on your past, or maybe when you look at the present, and when you hear the word medicine, let me just ask a first general question. What is the first thing that comes into your mind when you hear I'm doing medicine? What does that mean to you?
It's really about helping people. Medicine is at its core is about helping people. Think about it. There are people that are in their most vulnerable time of their lives that are entrusting you with the most valuable thing in their lives. This is what medicine is about. I mean, at the end of the day, patients have to be front and center. There is no other profession really because the most valuable thing in a person's life is really his or her health. If you don't have it, you just cannot do other activities. And when it's compromised and it's threatened, and you have that person that they trust in you, you better be worth their trust. And remember, they're meeting you for the first time sometimes, right? I mean, you're getting this person coming into your clinic, into your office. Sure, they may have researched you. Maybe they got a recommendation. They've asked about you. A friend told them they've seen you. I get all of that. But at the end of the day, they don't know anything about you. And you need to establish trust with them fast in their most vulnerable time. So medicine is about helping people, whichever branch of medicine you're in, whether you are working in academia, in community, in industry, in teaching, in just pure research. At the end of the day, the hope is that you put patients front and center in what you're trying to accomplish.
And when you say it like that, one could have the impression that it's either a challenge or even a burden that comes with that explanation. Do you felt that when you first started out in clinical practice? Do you felt that responsibility, the insecurity, maybe even to try to figure out, okay, this patient comes, as you said, to me with a lot of questions and with that delicate situation, and how did you handle that, or what do you think is really important to handle that difficult situation?
Yes, I felt very insecure at times. I think it is important to be humble in medicine. The most successful people in the medical profession are those who are humble, who recognize their limitations, and who admit that sometimes they don't know it all. In fact, one of the things, and I don't want to digress from your question, but one of the frustrating things about the COVID-19 pandemic is all of a sudden we were like flooded with all of these experts who absolutely know everything and they're 100% correct and everybody else is not as smart. And it got on the verge of being disgusting, to be honest. That's why I don't even engage in these discussions. But yes, I mean, when you start medicine, you're unsure, you're not certain, and you question yourself, am I doing the right thing? Is this the right situation? And I have asked people, I've asked trusted colleagues when I first started, when I was faced with a difficult condition, with a difficult case, because ultimately it's not about me. It's about that patient in front of me who I need to help. I've had cases where I've seen the patient, I've reviewed the cases, and I went back and I studied about the case to make sure that I understand everything and so on. And with time, you gain more confidence, right? And you start seeing similar cases, and you become, you become more comfortable, A, in your own skin to know exactly when you have to ask for help, and B, you just expertise comes in. But I wouldn't say it was a burden. It was just more of there are certain cases where you're a little bit unsure, and you want to unsure of your decision making, especially the first year in practice. And I think that improves with time in any profession, right? I mean, so you're a lawyer, and this is the first client that comes into you, or you're a lawyer, it's the first time in the courtroom litigating a case. You're an accountant, and the first time you are doing financial accounting for a corporate. And I mean, in every profession, the uniqueness about medicine is it is directly related to other humans' life and health. And sometimes if you make a mistake, it could be very costly. So you have to really think very carefully in every decision that you take.
And doing this step from going from Syria to the USA, I cannot imagine what that must have felt like, because I'm living in Germany and doing German stuff, seeing always, let's say, my community, etc., not really leaving one whole environment and putting myself in a completely new situation. What was that like? Did you even had like felt kind of difficult, like what phases that you were confronted with, like different views that people, okay, he's from abroad, what does he want from me or something? Did you feel this kind of, I don't know, challenge or even disappointment sometimes, or was that okay for you to handle?
I mean, it's up and down. I think the US is just a little bit unique, honestly, just because almost everyone kind of is an immigrant, to be honest. I mean, it's a little bit different than Germany, a little bit different than even a lot of other countries. The US is really, I mean, everybody in the US must have come from somewhere. I think in the beginning, I mean, there are times where I did feel frustrated, scared, being alone, having no friends, and I had doubts whether I will really be able to be successful. And there are some times where I just felt I'm just going to leave this whole thing and just go back because I'm done. I mean, it's just, you don't have money, you're lonely, and you have so much responsibility to pass all the exams, and you don't have really an outlet, no one to talk to. And when you want to talk home, at the time when I first came in, there was really no WhatsApp or Viber or anything like that. You had to pay money. I mean, it was like $2.50 per minute to pay. And I remember the first bill I had from my phone was over $500 and almost a heart attack. I didn't even have that much money in my bank account to pay the phone bill. So you get through these things, but I have to tell you, Nico, I don't think this is honestly unique to me. I think every immigrant get the same thing. Like, I don't feel this is something special that, oh my goodness, I've accomplished something that others have not. I think there are so many stories out there, and many stories, honestly, way more inspiring and better than mine. I mean, my story is I was lucky enough to come to the US. I was lucky enough to have some money to be able to get started, and I just, worked hard to be able to get the test and so on. But there are way more, honestly, inspiring stories. But I did have doubts, and there are times where I really thought about leaving this whole thing and just going back, and then maybe resilience, maybe perseverance, which are the fun words to say. But I'm going to tell you, it wasn't probably resilience or perseverance, although these are the buzzwords, right? That will make your listeners, oh my goodness,
Yeah.
his resilience.
Yeah.
It was shame. It was the shame of going back and admitting failure. That was it. It was, I'm like, my goodness, what are they going to say about me if I go back and I don't really make it here? That was it. It wasn't, I mean, I'm glad I didn't, obviously, but the reason I didn't was I was ashamed of admitting failure and defeat, and I said I'm gonna keep going and see what happens for the next year. That's how it worked.
So shame was a force for you, which drove you forward. Okay.
And I still have a chip on my shoulder every day. I think that it's exhausting, to be honest. I wish I didn't. I'm not going to lie. I think it's a little bit tiring to always have a chip on your shoulder that you want to prove something or do something and stay relevant. Because, if you have it, it's good. It keeps you going. It keeps you motivated wherever you are. But it also could be exhausting because you may not get to that level of satisfaction where you say, okay, I've accomplished something. Let me sit back, relax, and enjoy the music.
And when you say it like that, that brings me to another question. I always have, when I first started out, which was like 5 months ago, when you practice medicine, how you should go to a patient with a different background. You have a different background as a physician. And what do you think of the role of culture and religion in medicine? Do you think a physician would need to integrate all of these things, or do you think let's better leave that objective out of the room and just talk like business, facts, etc.? Or do you think a good physician needs to try to understand and to try to integrate all of these things?
There's a lot in this question, obviously, to unpeel or to peel or to unfold, if you will. So, look, obviously, people are a whole. What makes an actual patient is a combination of everything, right? I mean, what makes you the person that you are is the culture that you were raised in, maybe some component of a religion if you're a religious person. Many people are not religious. Could be political views as well, might actually make you believe certain things or not. I mean, that's what makes who you are. And then when you come into the office, you can't leave all of that behind you. You're still who you are when you come and see me as a patient. Here's how I would answer that. I think culture is important to incorporate when you're taking care of people, because there are certain cultural beliefs that are going to dictate what you can do and what you cannot do. And you really have to be open-minded to the variations in culture, right? I mean, it's just the way it is. I mean, I'll give you an example. If I was taking care of a patient and there are certain cultures where don't tell the patient that what he has. And we're trained that you always have to be open and telling the patient what he has. And usually I would face that by looking at the patient in the eye and say, your family doesn't want me to tell you what's going on. Is that okay with you? Do you want me to talk to them alone? And you'll be surprised. Sometimes I say, They say, yes, sure. I really don't want to know. They're taking care of things. But at least he or she gave the permission for that. And you have to be open for that. I think culture is more important than religion in situations like this, and way more important than political views. Physicians need to take care of people regardless of their religions. I have taken care of people from every single religion around the world, including no religion whatsoever. And that, even if you disagree with that, you still have to, take care of the patient in front of you. Political views have to stay out of the window. I mean, you may feel strongly about particular political agenda as a person who lives in Germany. You may be completely, one party versus another and so on, and you get this person in front of you who is completely opposing to you, and that should stay out. If you talk about it, it should be like in a joking manner, in a way just to break the ice, but it should not really play a role in how you take care of an individual. I think the culture is different breed because you really have to factor that in. And I think some cultures are dictated by religions, but I don't think it's always the case. I think religion sometimes and culture are not always interchangeable. But if you're taking care of someone and he is very religious and says there are certain things, my religion precludes me of getting a blood transfusion, you'll have to respect that. And you'll have to say, okay, let me see how I can treat you in a way that maybe I will minimize the risk of a blood transfusion. And you'll have to ask the difficult question. What if it comes that a blood transfusion is going to save your life? What do I do? And he or she will have to decide what to do then. So you factor all of this in as you take care of people, but don't be judgmental. Like, don't get out of the room and this becomes a water cooler conversation. Oh my goodness, I took care of this person who is X, Y, and Z. I can't believe blah, blah, blah. This is just not right. And it does happen, unfortunately.
I'm jumping a bit back and forth, but let me just go back a few moments where you said how you overcame difficult situations and that shame could be a powerful source. I think that should be outlined in future assessment center trainings. I think that's a really powerful statement. But did you also have maybe figures, specific people who influenced you, who made you overcome difficult situations, from whom you learned most things, or who you influenced you in a very specific part of your life?
I mean, in the beginning, as you start, you obviously always are influenced, at least for me, by my parents, because I always felt that they worked very hard to get me where I was, and I was very afraid of disappointing them. It really was just about the feeling that I need to prove to them that I was worthy of their sacrifices and of their trust in me to get me here. I mean, I'm forever grateful because I wouldn't have accomplished anything if it wasn't really for my parents at the end of the day. I mean, I think that you meet a lot of people throughout the journey in various phases of your career, where it comes to residency, fellowship, and then as a faculty attending, and different people influence you differently, and then they shape you to make you the person that you are. I mean, obviously, when I was in training in fellowship, I was very influenced by one of my mentors, who was the director of the Northwestern Cancer Center at the time, Steve Rosen, who is currently at the City of Hope as the chief scientific officer. And I worked in his lab, and I really loved what he did. He was able to be a good clinician, a good administrator, and also had an active lab. But really what I appreciate in him the most is his mentorship and his ability to push me into meeting people, getting me to know new people and all of these things, which not every mentor is able to do, because as a mentor, you have to give up on certain opportunities and give it to your mentees so you can make them grow. And he did that. But I would say in the beginning, first and foremost, were my parents. And going back to shame, by the way, I think vulnerability is very important, right? I think vulnerability is, admitting that we could be vulnerable to anything is okay. It's really what you do with that admission and how you take that and help you. Like I said, it could be very exhausting. I'm not gonna lie, but I do think it could be very powerful in making sure that you continue on the path. The biggest risk that you could face is when you feel you're it, like there's nothing that could shake you. You are God's gift to medicine, hematology, and oncology, and that is very risky. That sense of arrogance, or you've achieved everything and you cannot learn anymore, is a big problem. We always can learn more. We don't know everything, and we should always continue to strive to learn more.
I think I made the observation that one specific factor for this kind of fight with vulnerability and fight against it, unfortunately, and many people in my university hospital here, is that we are obviously confronted with death. And you pointed out that patients give us their lives. And I read one really nice phrase from, I don't know who he was. It was in the newspaper some time ago, and he said that doctors tended to try to make medicine everything about life, but in the modern era, it's always about death, mortality, and postponing the death, etc., and not caring for the life of patients. Let me then ask you one completely general question, which could even make a whole podcast episode. But when you hear death or mortality, what comes into your mind? How do you think of death? What does it mean to you as a physician?
Okay, I was going to say you have to look at this as a physician or as a person. I think as a physician who is caring or has cared for a lot of people, death is definitely inevitable. Is really inevitable. I mean, it's unfortunately it's inevitable, because life could be enjoyable, and I think that we probably all fear death, despite the fact that we know it is going to happen. And we also sometimes think we are invincible, because when you are healthy and feeling fine, you don't expect that to happen to you or to others. Let me start by answering this by looking at ourselves, right? Because you have to think of the patient in front of you as you, because this could be you. I mean, at the end of the day, I've said that many times, we're all going to be patients. We probably already have been patients, but we are going to be patients. I mean, there's no one who's going to escape hospital care or who's going to escape seeing a physician. That's why I actually want the new generation of doctors to be good, because they're going to be taking care of me. So I'm concerned. So the way you view death could actually portray the way you view death when you're taking care of patients. I think death, to me as an individual, portrays fear, as well as anxiety, as well as unknown. I'm afraid of it, I think, because I don't know how how it's going to happen, right? I mean, when you think about it, I just don't know how it's going to happen to me. I don't know what's going to happen afterwards. That you bring now religion and culture, and you can pick and choose the religion from whether there's afterlife, whether there's nothing, all of these things. And then also the fear of leaving loved ones that you actually grown to love, and whether it's family, children, relatives, and all of that. So if this is how I feel, then it's probably how my patient also feels. There's nobody with you in the room who's confronting his own mortality, who's so excited about it. So they probably have the same issue, the fear of how it's going to happen, the anxiety of leaving loved ones, as well as what's going to happen afterwards. So the way you approach that with the patient, when it comes to what might happen afterwards, depending on the religious beliefs, whether it's Christians, Jews, Muslims, you probably get them to meet a religious figure that you work with. Could be, again, to talk about these issues. How it's going to happen, I think it's an important aspect to discuss with patients, especially as things get worse. If you are caring for them and things are not going well, it is okay to sit and say, look, you should not have any pain, and we are going to actually work to make sure that pain is not going to happen when that day comes. And this is how we ensure that this won't happen, and so on. As far as the leaving loved ones behind, you emphasize that you're going to do everything possible to have better quality of life, spending time with their loved ones. And if there's time when you need to pull back and stop giving chemotherapy that's going to cause them side effects that are detriment to the quality of life, and so on. So that's how I would approach things, because these are the things I think about. So I presume these are the things they're thinking about: the fear, the anxiety, the loved ones, and then the religious aspect. And I try to approach it from a multi-dimension process.
You wrote in my view, really beautiful piece in the Journal of Clinical Oncology about the last hug. And I really think it's everyone should read that. And if I may, I would just cite one short paragraph and then ask you a question on that. It starts with, we met on a beautiful sunny day, and as I was driving to our meeting place, I wondered if I had made the right decision. I was not sure how my colleagues would react if I were to tell them about my patient encounter. When every non-urgent medical visit was being characterized as non-essential, I would have risked being labeled as reckless. Sharing this planned, endearing encounter with few trusted colleagues and my family would not have been unusual, but the fear of their disapproval made me keep this to myself until now. Deep inside, I knew it was the right thing to do as a physician. It's maybe good for people out there who didn't read the piece to just state about what the whole thing was about, and then what do you mean? What was the right thing? What did you do right in your point of view?
Well, I definitely did the right thing, but I think that if you take your mind back to 2020 and how polarized that year was, I mean, even on social media that we just complimented when we first started the show, and we talk, this is the other edge of the social media. I mean, it's not unusual for me, for example, to tell a few friends, you know what, a dear patient of mine called me and I really want to go and meet her with her daughter because of X, Y, and Z, or like even telling my own family, you know, I'm just going to go for like the next hour and a half because I'm going to meet a patient. But it was such a taboo to do something like this that you would be even anti-science. Like, how dare you do something like this? This is blah, blah, blah. I mean, this is reckless of you, anti-science. And I didn't even, you know, it's not unusual to share something like this, of course, with as long as you keep the patient's name and so forth anonymous. But I do honestly believe that had I said that to some of my colleagues, or even had I even tweeted about it or mentioned it last year, I would have been labeled very differently. Look at this, he's jeopardizing, blah, blah, blah. He's doing this. We have the evidence-based medicine. You need to be always away, always, all of these things. And I think it's easy for you to sit on the couch and pontificate and tell people what to do and what not to do. But at the end of the day, every case is different. Every situation is different. And that's why actually I never wrote this until a year later, because I always said, it's not something really, like, it's not a big deal. I never felt it's honestly a big deal, because physicians should do that. You should really do what your patients want if you feel it's appropriate. It's a human, medicine is a human profession. But the more polarized life has become, I don't know how it is in Germany, but in the US, it became so polarized. Like, I felt, I really, you know what, I'm going to write this. And hopefully JCO will accept it. I mean, you never know, you submit it and they may not like it. But I felt I need to write this because I wanted to make sure that people realize when they do a white label on everything, like, oh, these visits are not essential. You don't know that. You're not in the patient's brain to tell what's essential, what's not essential. Maybe it's not medically essential because there's no chemotherapy I'm giving, no radiation, no nothing. And I write that in the article. But what if it's humanly essential? There's a humanly essential. This is really the part of the profession that we really need. It's humanly essential. We are not robots. There's a human interaction that we need to do. And I felt strongly then about writing this. And when it was peer reviewed, actually, they did ask me to comment on that, what I meant by that. And I elaborated on that further. But I really was afraid of mentioning that. I felt I would be attacked on social media for saying this, because people will say you're making a mistake, you're not setting an example to other people, you need to lead by example. So I kept it to myself, and she's my patient, I'm her doctor, and I will meet. I realize it's important to her. It was also important to me, to be honest. I felt, as sad as it was really, I felt it was something that is so good that I did during the pandemic. It's hard to describe. Sometimes you do something like this because there's nothing tangible except the emotional sense that you have inside of how well you feel. You know how you just get the internal sense of being content. You do something and you just feel good about it. And you can't sometimes describe it or articulate it. I'm glad that you read it. It really was something that I felt strongly about sharing with people. I'm honored that JCO accepted it because, I'm sure they get a lot of essays and so on. So I'm hoping others read it and relate to it. The idea to relate to it is we all have done certain things. All of us have done certain things that could be against guidelines, against strict rules and guidelines that are dictated by somebody who is in the hierarchy and so forth. But we have our reasons to do it. Some of us are just rebels and just want to violate guidelines, but we oftentimes have a good reason to do that, right? I mean, take medical tests to treatment. Sometimes you do have to do a test that maybe the guidelines tell you not to do, but you have a good reason to do it because ultimately you're the one who's taking care for that vulnerable patient in front of you.
I really liked your description of the existing parallel of being content and feeling the pain, and that you said, okay, this step is she will die. That's hurting me, but I need to do that to feel good and to make her feel good. And I encounter that in my first days every time, that I need to prepare myself for being okay. I want to do that. I think it's the right decision, but it hurts. And because in our university, you often see professors who are these stones who make decisions and stand by it and you don't have a clue how they feel inside, etc. And you sometimes think, okay, are they really reflecting on that? What does that mean to a patient, this decision? And do they take that with them at home and work on that in their nights or in their bed? I really like this description, because I think it's a really good for young people to see that people who are experienced also still feel that, and that this is the thing maybe that, I don't know, would you think that will never end until you finish being a physician?
Just don't lose that sense of humbleness and humanity. That is really so important. Like, you know, you're right. Sometimes as you get older in your career, there are many other factors that shape how you change in the way you take care of people. And sometimes burnout, sometimes you're very busy, sometimes competing responsibilities, sometimes even your research career. You just want to enroll patients on trials, and it becomes like almost a robotic thing that you are doing. It loses the human touch, and that is a big problem. Patients know. Look, patients are smart. They know the person that cares genuinely for them from the person that doesn't. And in fact, there are many times that patients tolerate someone that may not be very genuine or very humane in the way he cares for them, because they think he or she is good. Well, you know, I know she or he doesn't have good bedside manners, but he's a great surgeon and I need the surgery. You hear that all the time. You know, I need to have a Whipple surgery. I could care less whether he's really going to smile at me and hold my hand or not. So I think, but patients know. It's not that they don't know, but they're willing to overlook some of these shortcomings that physicians have for their own reasons. And some of them, they're not willing to overlook that because they demand it, they really need it. So I think the most important thing is to always carry that and stay humane to the nature of the profession. That is my opinion. I think it was going to make every trainee and every future physician always feel good about what he or she is doing and the sacrifices that you're making. The medical profession is not really a profession, it's a lifestyle. I mean, truly is not a profession. It's not a job that you just, you know, go back home and you're done and you shut everything in. We should sometimes do that, but it's very difficult. It's really a lifestyle. You chose, nobody really forced you to do that. Nobody put a gun to your head and said you absolutely need to do medicine. Now that you did, then you need to get your part of the bargain. And it is a lifestyle. You have to be available. You have to take care of people. You have to take care of patients. You don't like it, then you have other professions you can actually do, but not medicine.
I like that. I think that needs to be a t-shirt. Nobody forced you. Nobody put a gun to your head and forced you to become a doctor.
Nobody did, right?
Yeah.
And yet you hear people complaining about certain things. Like, you could do something else, really. I mean, you could do something else. You don't need to do medicine. But if you choose to do medicine, that's what it comes with. That's what it comes with. There are certain things that we need to be flexible about, right? And accommodate, and no question, right? I mean, work-life balance remains important. I'm not saying just ignore everything, but I'm just saying there are certain elements in medicine that are very difficult to change just because of the nature of the profession. These are people's lives in your hands. I have given my cell phone to many, 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 many of my patients. I've never met a patient that abused the cell phone number that I've given them. Almost all of them had my email. They're able to get me on Twitter, wherever it is. And, you know, nobody has ever like reached out to me unless they really needed to reach out to me. So I think patients are so respectful of what physicians are doing. Of course, there are always exceptions, right? You always have the couple of people that you exception, no question about it, but for the most part. So, I mean, I plea for physicians to maintain the human nature of the profession and to treat it the way it is. And trust me, every single patient knows if the physician in front of them genuinely cares about them, or that they just treat you like one of the bunch. They know.
You also mentioned difficulties since last year, especially since the pandemic. What do you think? Did COVID already change in medicine, and do you think it has already changed medicine for coming years and maybe even permanently? What do you think has changed or will change with COVID, for good or for bad?
Yeah, I mean, look, in my opinion, I think the public, I don't know how it is in Germany, to be honest. I can only comment on the US. And I would say that I don't blame the public for losing their trust in the public health officials. I really don't. Look, let me give you just a few examples. So it's in medicine and in science, we have all grown and taught to ask questions, right? I mean, your professor tells you, ask questions, inquire, research, go read, investigate. I mean, that's what it is. That's what medicine is about. COVID-19 brought in so many taboo questions where even if you are seeking knowledge, you're not allowed to ask. Because if you ask, you will be labeled again as reckless, as anti-science, as anti-vaxxer, all of these things. I've never seen anything like this. If you ask, if you try to say, you know what, I'm concerned about the possibility of myocarditis that might happen in young kids if they receive the vaccine. I'd like to know a little bit more about this. Oh my God, you've committed a crime. How dare you do that? This is wrong, but I just need to ask. If it's okay to ask, right? I mean, there's nothing wrong in asking a question. If we never asked a question, the earth would still be labeled flat today. But somebody asked a question and then we discovered it wasn't flat. But I think what COVID-19 did is it really made people scared about inquiring about certain things. And that is the art of medicine, is to ask questions. The other thing that COVID-19 taught me about people is that people forgot that everything in life is about trade-offs, and there's a risk-benefit ratio to what we do, right? So in medicine, you have a patient and you decide that this patient required a cardiac catheterization, an angiogram, right? And you need to do an angiogram to check for the coronary arteries and so forth. Angiograms do have potential problems. You could have a lot of things, hematomas, people get stroke, whatever it is. They're very rare, they're very unlikely in the hands of an experienced cardiologist. But the risk is not zero. And you make a determination that the benefit that this person has from doing the procedure is more than the risk, and hence I'm going to do that. And we need to apply that into COVID-19 as well. So for example, we know for sure that the vaccines absolutely saving lives. It's probably the best thing that could have ever happened to us over the past year and a half. I would have never guessed we're going to have a vaccine by now. So nobody is questioning that. But for a given individual, for let's say a 10-year-old or a 12-and-a-half-year-old who is otherwise healthy, whose parents are vaccinated, whose teachers are vaccinated, maybe in that particular individual, the risk of the vaccine is more than the benefit of the vaccine, and it's okay. Now you take another person, the risk may be higher, and then they need to be vaccinated. I just want people to treat this, I mean, like that's how we do it in medicine. I don't think that happens anymore. And I think COVID-19 has changed people forever. I think it has polarize things. And initially in the US, it was blamed on politics and all of these things, as you know, and it's really not politics anymore. This is not politics. This is the bad side of medicine, where you are not open to listening to other people who may have opposing views, who may be concerned. Somebody could come to you and they say, I'm not going to get that chemotherapy. And you have to explain to them that the chemotherapy benefit outweighs the risk in their condition. They may still say no, but you do your best. I don't know. I mean, I'm a little bit disappointed with how public health officials have been very opinionated about the general public who was genuinely worried. I mean, there are many of these people who took the measles vaccines, the polio, everything, but they're just a little bit concerned about reports coming from all over about myocarditis, and they're being silenced. So we need to remember that we need to be open-minded to other questions that we may not agree with. We need to discuss these questions with people, and I think the public is probably scared of sometimes voicing their concerns, because if they do, they're going to be labeled, like I would have been labeled last year if I told people I was going to meet my patient.
I think it's the same in Germany, to be honest. It's the same experience we have here, and I wonder sometimes maybe you can try to figure out that, but I wonder if that comes from the dilemma in medicine, that whether there is a difference between medical practice and medical science. And because what you described, the decision making, in my point of view, would be a medical practice decision, where you see that patient and you decide, okay, in that situation, I would recommend it based on that, But the science behind that is completely, is always, in Germany, for instance, is always, the argument is always, yeah, science tells us, or the scientific data show that we can do that safely. Okay, really? Did you really practice that in real life? I don't know whether this is the problem, whether people feel that there is an insecure gap between reality and science.
Well, you have to think of population health versus individual health, right? So I'm just saying, let's take a prospective randomized control trial of whatever discipline. Let's take oncology, because I'm an oncologist. You have a randomized control trial that compared one drug to another, and drug A proved to be superior to drug B in this prospective randomized control trial with a statistical significant value, and was clinically significant. So the survival difference was 6 months, and the p-value was actually less than 0.05. So in this patient population, let's take a patient population of prostate cancer. In the patient population of prostate cancer that meets the inclusion criteria and exclusion criteria of that particular study, the benefit of drug A is more than drug B. It is statistically significant and clinically significant. Great, we know that. Now you're in your clinic and you get a patient that comes to you who has prostate cancer, and you need to make that decision. For that particular patient, you cannot tell that they are going to derive the same benefit of the population. What you could tell that patient is, I know based on this study that you are more likely to benefit than not for drug A versus drug B. You cannot be certain they will benefit, but you're more likely based on the trial. So you feel comfortable about it. But for that individual, they may have specific things, and you as a clinician, you realize that benefit may not be substantial. Maybe actually there are other issues. Maybe that drug has certain adverse events, and this person could have more problems and so forth. And that's where you factor everything and you say, you know what, I thought you probably would benefit more with this drug, but in your situation, maybe let's think about something different. I mean, that's how we do it. We do that all the time, all the time. But it's not allowed to be done when it comes to COVID-19, because it's just a taboo. It is just a taboo. Can't do it. So be careful what questions you ask when it comes to COVID-19.
Yeah, in Germany, there is a really nice observation we had, because we have this Professor Drosten. He is a virologist, a really glorious figure in coronavirus, because he really specialized himself in coronaviruses during the first SARS pandemic in 2003, and the MERS virus, etc. And he started the podcast last year on February with a public network, and they asked him, could you try to discuss for the general public out there what the coronavirus is and what the situation is. And the first 3 months were, I think, public health wonder. It was really, the whole country felt informed. He really did a good job. He just focused on his side of the view, his biology of and virology of the virus, etc. And then there was a tipping point. I don't know when, but when this information changed to public health and to measures and to what shall we do and to the vaccines, and then the whole situation became vague. Yeah, he said, yeah, I would recommend to do the vaccine and to close schools, and you already felt, well, what where did you come from? Why did you say that? You're a virologist, stick to your knowledge. And but the pandemic somehow felt that everyone wants to what you said.
Nico, at least he's a virologist. In the US, you don't need that. You could be an emergency room physician. You can be a cardiologist. You could be a pulmonologist, a nephrologist. It didn't matter. Oncologist, everybody became a COVID-19 expert. Everyone is an expert. You don't have to be infectious disease or a virologist or even a policymaker or public health. Every single person became suddenly an expert, and a good expert overnight.
And you think that will stay with us for the next years? You think that changed everything?
Well, I think it depends what we encounter. I think if we get another pandemic, for example, I think public health in my opinion, public health officials have failed the public. And I think it's going to be very difficult for them to get credibility and for people to follow their advice, because it was felt that they had a different agenda and so on. So I don't know. We'll have to see. I think there are always some few good voices out there that were really trying to educate and to help. But I hope things get better. I think my only ask is really, it is okay to ask questions, as long as you're asking to inquire. I mean, really, sometimes we know that if you're asking to be, just asking to be obnoxious in the question, but most people are really asking, seeking knowledge, because they're confused, they're concerned, they're really, if somebody has a child, they're concerned about their child. They're not, they already got the vaccine themselves as an adult, so clearly they're not anti-vaxxers, but they're concerned, and it's okay. We have this. Let's just figure out how to address this, and maybe in that particular individual, it's okay not to give the vaccine. I just think we need to allow people to ask questions freely, acknowledge that this is what science is all about. We're in a very good situation that we have these vaccines, but COVID-19 had made people not comfortable asking a lot of questions, seeking knowledge, including myself. And I believe that I'm not alone. There are many people who do not feel comfortable asking questions anymore. And the public reads Twitter and social media. They see what happens. They see how people fight each other, and they discuss with each other, and they're taking notes. They're all taking notes, and we'll see what happens when we are faced with another crisis, and who's going to emerge as the winner. I hope not, but who knows?
At the end, let me ask maybe two final questions, because maybe also related a bit to the COVID pandemic, because you also wrote a piece in JAMA Cardiology about virtual visit. I think it was from your dad. What was it?
Yeah.
What do you think of that? Do you think, let's say, 10 years time, we all do virtual visits and virtual recommendations?
Yeah, look, I think the virtual platform is here to stay. It's not going to go away. I think we just need to make sure that it is utilized appropriately for the right people. My biggest concern with the virtual platform is that the people who decide which patient to be seen on a virtual platform versus not are not the physicians. I think in an ideal world, what you should do, for example, you look at your next month's schedule and you can note which of the patients you're seeing in the next 30 days could be seen on a virtual platform. Now, remember, that means that the patient has a virtual platform. They have an internet, they have a computer, they have a Wi-Fi, which, as you know, in low middle income countries, it's not easily accessible. It's obviously not a problem in Germany or the US, but we're talking, if you want to globalize this, it's not easy, it's not going to happen. But let's say for the first world countries, that when this is accessible, you go through your schedule for the next 30 days and you make a decision, maybe who are the patients you're going to see virtually. This empties your schedule, allows you to see new patients coming in and take away some of the stress on your schedule, because oftentimes it's difficult to see patients timely, especially newly diagnosed patients. My concern is that the people who make that decision are not the physician, like some administrator or a hospital administrator or a president of the hospital, whatever it is, comes in and says, okay, you know what, we're going to do all return visit as virtual, and you're only going to see new patients in the clinic. And that doesn't make sense, because many return patients need to be seen in person. I think there are certain specialties that have to be in person. It's very difficult. But I do believe there's a lot of good things about the virtual platform, because you get to see people who are going to travel from a distance. They have to pay for parking. I mean, there are other elements that are very good. So a hybrid model, in my opinion, is going to be the future. And I think physicians need to be heavily engaged in making decisions which of their patients needs to be seen virtually versus in person. But there's no question that it will help a lot of people.
Okay. And what are your prospects or plans for, because let's come back to the start where we came from. What are your plans? Do you think you will do your podcast until you're doing your last breath? Or what are your plans for the future?
I'm hoping somebody will sponsor me, and then I can quit everything and just do podcasts for a full time. So, see, maybe EBMT would like to sponsor me and just
sure.
But I like it. I really do. I enjoy it. I mean, it's not something. I mean, I don't. It actually costs me money. I don't really make anything, and I like to grow it a little bit. I would love to have a larger platform, because I really like to bring a lot of guests to listeners. That the podcast is not about me; it's about the guests I usually bring. So I will continue to do it for the near future, as long as I have the time and as long as there are people that are willing to take time of their busy schedule to log in and to chat with me. Hopefully this will continue for a while.
Let's hope so. Thank you very much for your time. I really, really appreciate your time and your quick response. Given that we never met each other and didn't know anything about each other before, but I really, really enjoyed it. You spoke from my heart in very instances. It's really, really nice to feel reflected by the sometimes insecure situations that as a growing physician, you feel when you have all these questions, when you come to a patient and you don't know really, you don't know what you're doing at the beginning, and you just try to find out what you're doing.
No, I appreciate the fact you invited me. appreciate the fact that there are people out there who want to listen to anything I have to say. That's always good to hear.